Once again, you're watching Boritzer's Bio Briefings, where you're hot and we are not. But our guests are very hot, and we're going to be discussing a very hot topic today. My guest today is Dr. Thomas Kosasa, Professor and Chief of the Department of Reproductive Endocrinology. And so, you're going to ask him about a cold? No, not today. This is a different kind of cold. This is coming into the warmth of human life. And we're going to be talking about reproductive technologies, behavior, treatments, issues, terminology, definitions, and on and on. And Dr. Kosasa is really brilliant. He's one of the top people in this field. And I know that most of the people who live in the state of Hawaii and the Pacific depend upon his knowledge, experience, adequate familiarity with technology, and he's up on top of everything that's happening. And he also is going to tell us, perhaps if we have a chance, about the conference that Hawaii is going to host in reproductive endocrinology later on in the year.
In October, yes.
In October, okay. Yes. What is the name of the organization exactly?
The American Society for Reproductive Endocrinology, and it's the top society for people trying to have people become pregnant.
Wow, wow, wow. So let's start off right off the top of the bat. You know, what we hear about, people make jokes about sperm banks, or some people take it seriously. Those who have a vested interest take it more seriously. We hear comedians making fun of sperm swimming and so on. But what exactly are the problems that a person would want to even consider something more than what we call natural fertilization and childbearing and pregnancies and so on?
Yes, you know, one of the major breakthroughs that we've had in infertility is that the cervix actually is the opening to the uterus, which then leads to the tubes and fertilization of the egg. And what happens is, as one gets older, this cervical mucus becomes thicker and thicker, and the sperm just cannot get up there.
So let me ask. So one of the common things that we often hear, especially for, let's say, we'll call them old wives' tale, if you don't mind the expression, just give it time. You'll get pregnant eventually. You're just nervous. You're just tense. You're having too much stress at work. Is this
doesn't work?
That's not an explanation.
No, that's an old wives' tale. And what happens is that as one gets older, the age of 24 is our break point. After 24, it becomes harder and harder to conceive. And so whoever designed this to become pregnant at 13 and 14. And
please, this is a family show.
Right.
Okay.
Right.
No, don't try this at home, okay? Right. If you're 13 or 14, please, don't be even watching this show unless you need it for a school project.
And that's why they get pregnant one time in the back seat of a car. And so whoever designed us to be actually gone by the age of 29. The only thing I remember from Greek and Roman studies was that the average age of a Greek woman was 29. So you had to conceive at 13, 14, so you had about 15 years to bring up your child.
So what are the symptoms that you're infertile on?
Well, you know, we say that after 6 months, if you haven't conceived and you're over 35, you should see someone, because 35 is another break point. It becomes much more difficult to conceive after 35.
Can you tell from your menstrual cycle that something is wrong?
That's hard, actually. You'll have periods every month, and so there's nothing that you can put your finger on to tell you that you're having a difficult time conceiving. And so, as I mentioned before, the major breakthrough was to take sperm and wash it and take off what we call prostaglandins, which if you put regular sperm into a uterus, it starts contracting and people have severe cramps. But if you wash the sperm, concentrate it, and then bypass that cervical mucus into the uterus, you really double your chances of conceiving. And so that was one of the major breakthroughs of infertility.
Well, you often hear when you talk to people who are experiencing difficulty, achieving conception and a pregnancy, there's a kind of a blame game. Whether it's internal to the family, it's male infertility, no, it's the woman's problem in this. What are some of the male infertility issues?
Actually, it's about 60% on the female side and 40% on the male side, almost 50-50. And we're finding out now that the sperm count in the U.S. male population is decreasing. We don't know why. So again, we have the technology to overcome this fact, but it's almost 50-50 now, that half of the problem is due to the wife and half to the husband.
So looking at it historically, I mean, I've never really met. You're the first reproductive endocrinologist I ever met. I always thought endocrinologists just dealt with all kinds of glandular problems, and I didn't realize, even though the reproductive organs are glands, but I never realized that there was such a specialty, because it was assumed you didn't get pregnant by the time you're 35. You either didn't want children or you couldn't have children. That was the end of it.
That's
what was
correct.
the breakthrough that happened?
I think people just became more knowledgeable about the fact that, you know, if you didn't get pregnant, that there might be something that could be helped. And so they've developed the subspecialty, which was only in the mid-'80s, actually. The subspecialty was developed probably 83, 84, and so it's not that old. And so, and in vitro, actually, we started that in '85 here in Hawaii. The first baby born was in 1978, but that was, you know, kind of a super major breakthrough. But for the most part, the first IVF baby, and IVF means taking a woman's eggs, fertilizing it with her husband's sperm, and putting the embryo back in, was '83. So Hawaii was just 2 years behind the first IVF baby in the country.
So let's put on slide number 3, please. Okay, now this is the way, is this the way we would see a sperm under a slide?
That is correct, yes.
Okay.
And those are good-looking sperm.
Well, I see. Those are the survivors, you
those
say.
Are survivors,
yeah, those
right.
are survivors.
Right.
And I guess good sperm and bad sperm are differentiated by the fact that the good sperm survive until they are able to perform.
Yes, yes.
Okay, and so what are some of the, what would you say are the statistics of infertile males?
I'd say that probably 20% to 30% of males, when they try to have a baby, are going to have a difficult time. So not as high as women, but again, because of the age factor. I mean, if a woman is 40, then her chance of conceiving are less than 20%.
I see. What are some of the common problems that males might have? You know, I have a personal interest being a male, so
Right.
that's why I'm asking these questions, but we'll get to the women very shortly.
You know, for males, it's just a lower count, or the sperm are slow, or
What is that, motility? Is that the sperm?
Motility, yes. And or they don't look good, or the sperm swim around in circles. You know, they don't go straight.
So they're malformed in some way?
And that's called morphology. And so those are the two things, motility and morphology, and count too. You know.
And I've heard someone mention also in one of my conferences that I went to about blocked sperm ducts.
That's rare. That's
right. But it is a possible cause of low sperm count.
Yes, and then you have men with vasectomies. They, you know, in their first marriage, and then they marry someone else that's younger, and they have to have it reversed, and so that's another factor. And reversing a vasectomy is quite difficult. So with IVF, we actually take the sperm from before the blockage and then fertilize the eggs.
The only place I've heard about reversed vasectomies is probably on some crime show where someone gets murdered or perhaps attacked. But so that is a possibility, to reverse the sperm duct after a vasectomy.
Yes, but that's difficult. No one does that pretty much anymore, because that's an old microsurgical technique that very few doctors can do. But IVF is very easy. They just take the sperm before the blockage.
Well, I don't want to feel that all the males should feel attacked. So let's talk for a second about female infertility. And perhaps when they have a problem, what are the problems that female traditionally that ascribe to their infertility?
The main problem, I think, is ovulation. And again, as you get older, like after the age of 24, your egg doesn't come out every month on time, and the egg gets older too. So all women are born with their eggs at birth. which is something that
I see. So there's a finite amount.
There's a finite amount of eggs, and the age of the eggs is also a finite amount because every year they get older.
Oh, so the same eggs that you're born with are just staying around waiting for things to happen.
And with males, it's different because sperm are made all the time. So we have fresh sperm being made all the time.
Oh, so it's a question of being released.
Yes.
Is that the eggs are actually getting released. They are just being held in situ.
And they get older every year. That's why we have older women becoming more, having a problem having children.
I see.
And so that's the main problem. I think ovulation is probably the main problem of a woman having difficulty conceiving. The next would be, I think, tubal factors, where the tubes are not working properly. And in the old days, we would say pelvic inflammatory disease. And once you have an infection, then the tubes no longer work as well as they should. And so that's your second major problem.
Is that a big percentage of people?
It's not very small, thank goodness. And IVF also takes care of that because we don't need the tubes.
I understand.
We take the eggs out, bypass the tubes.
And what about abnormalities in the cervix or the uterus?
That's rare. That's
a rare. Okay.
So mainly the eggs and the tubes, ovulation and the tubes.
Okay. Now sometimes you're trying to track your ovulation, and can you do that? Can you actually find out what's the process, where the process is in?
Yes, what happens is there's what we call the LH surge. The LH luteinizing hormone comes from the pituitary gland, and there's a surge around day 14 in most people. And after that surge, that releases the egg from the ovary. And so they have these kits now that you can measure the LH surge.
So this is something you can do at home?
Ovukits, yes. And so once you start seeing it become positive, then you try to have a baby the next several nights in a row. And we've done studies showing that every night is better than every other night. There was a...
Every night is better.
Yeah, a long time ago we used to theorize that maybe every other night is better.
Yeah.
But someone finally did the study showing that if you have sex every night, your sperm count is up. But if you look at the baby's pregnancy rate, it's lower. So I tell my patients, do you want a high sperm count or do you want a high baby count?
I hear you. So. I think that's a very good point. I think people sometimes forget the goal and think about the process too much.
Yeah, so now we tell them every night. Once that kit starts to change every night for about 3 nights.
And would you show us slide number 6, please? What about fertility drugs?
Yes, Clomid is the most common fertility drug, and there's another hormone from the pituitary called FSH, follicle stimulating hormone, and Clomid actually helps release that hormone, and that actually helps to get a more mature egg and a better egg. We think it can fertilize a little easier. So Clomid's the number one first choice.
How long has that been around?
That's been around since 1964.
Oh, okay, so there's a good track record over there.
Safe,
oh,
yes,
okay. Well, we're going to take a break and come right back. Our guest today is Dr. Thomas Kosasa, Chief of Reproductive Endocrinology at the University of Hawaii, John A. Burns School of Medicine. And stay here. Don't go away. We're watching you.
Castle and Cook, Hawaii. Investing in Hawaii, creating communities, and providing for the needs of our state. Collateral Analytics, empowering the real estate industry to make better informed property investment decisions. The Foreign Trade Zone, bringing the benefits of the Foreign Trade Zone programs to Hawaii businesses and entrepreneurs. Galen Ho, a senior executive of BAE Systems, a global defense, security, and aerospace company. Hawaiian Electric Company and its affiliates Maui Electric and Hawaii Electric Light Company on Hawaii Island. The Hawaii Energy Policy Forum, incorporating diverse perspectives to design a flexible and forward-looking energy strategy. Hawaii Energy, the state's energy and efficiency program created to help Hawaii's residents and businesses adopt a clean energy lifestyle. Hawaii Gas, helping Hawaii achieve its transition to clean energy and a better energy future. Hawaii Pacific Health, bringing technology and teamwork together to transform healthcare in Hawaii. The High Tech Development Corporation, attached to DBED, is the state's leading technology agency. The Scheidler Family Foundation, supporting educational, cultural, and charitable organizations, including Think.
We're back. You're watching Boritzer's Bio Briefings. Your host, Dr. Rafi. I'm here with Dr. Thomas Kosasa, Chief of Reproductive Endocrinology at the JAB School of Medicine at University of Hawaii. And we're going through the process, so to speak, the news for the layman. What's been happening in reproductive technologies, behavior, procedures, science, results? Has there been a big improvement in results over the last 40 years?
Oh, I think so. You know, before in vitro fertilization, before clomiphene, or Clomid as we call it, the fertility drug, before intrauterine insemination, pregnancy rate was probably 10, 20%, 30% at the max. Now we can say everyone can have a baby. If we think of donor eggs or surrogate mothers, everybody can have a baby if they want a baby. So
really,
so it's
okay. And we're going to be covering all those issues because we hear about them more and more in the news media and the popular media. We hear about surrogate mothers, and I never knew that was a job, just like mechanical engineer. So I guess that there's a new job creation every day. Technologies change things and people's expectation of what is possible. And I think we don't want to go without mentioning that longevity plays a big role in modernizing the technology for the reproductive technologies, because people are living longer and they say, well, previously I thought my life expectation was 50, 60 years. I didn't want to start having children if I didn't have them by the time I was 20 or 30. But today people are saying, wait a second, maybe having a child and raising a child while I'm just retired from the job, that may be a possibility.
That's right. We say 70 is the new 50.
Yeah, exactly.
And we actually will help moms become pregnant at 50, 51, 52. And as long as you have a uterus, you can have a baby. And these are with donor eggs. And so the pregnancy rate's almost 100%. So someone could be menopausal and we could help her have a baby.
Wow. Well, we're going to some of the methodology and a little bit of the technology as we move along. We're just talking in the break about blocked fallopian tubes, and you mentioned that is not as common as it used to be.
Right. Blocked tubes used to be common, but not as common, thank goodness. And my training was to repair these tubes using microsurgery. But now with IVF, we don't even need the tubes. We bypass the tubes, take the eggs out, fertilize the sperm with a husband's sperm or a partner's sperm now, and put the embryos back in. So we don't need the tubes anymore.
So let's go into some of these procedures. The first one I would like to talk about is intrauterine insemination. Could you give us a little bit of explanation? What is this all about? You know?
Yeah, we had mentioned intrauterine insemination earlier because I think personally, as a woman gets older, the cervical mucus becomes much more thick, so the sperm cannot get into the uterus and up through the tubes. And intrauterine insemination actually takes the sperm of the husband or the partner and processes it. And there's three ways that it's processed. If a person has a very good sperm count, and sperm actually come out in almost like a gelatin form, and if the gelatin later on becomes less viscous or more watery, that's the normal physiological state. And so in these people, we just put a gel type of solution, and the sperm actually swim through the gel, and only the best sperm make it through the gel. And and we take that those sperm and then put them into the woman's uterus. So that's the first step. The next step is men who have like very thick semen. You know, the gel is very thick, and so what we do is we put the semen on top of the gel solution and then spin it. So we help the sperm get through the gel, and then take those sperm and then put them into the uterus. And finally, men who have really low sperm counts, we just spin the sperm down. And
so by centrifuge, they actually attach themselves to the side of the wall, like the old carnivals where they had these spinning areas, the centrifuges.
Well, this is still in a test tube, and then we gather all the good guys and then put them into the mom through the uterus. And so that's intrauterine insemination. And the process putting them in is quite simple. Just put them in and they're on their way.
Folks, you've heard about trainers in the Olympics. You were just finished the Sochi Winter Olympics. We have trainers for sperm. And I want you to know, this is the way Arnold Schwarzenegger survived. Only the strong survive. Now, it may have applied to being governor, it may have applied to being a movie actor, but now we find out that it also applies to sperms who want to be selected. So remember, training is critical. What about IUI with a donor sperm? How does that work?
Same. You know, sometimes men have very low sperm counts, and there's just not enough to help the wife or partner conceive. So we have sperm banks in California, and they have like young, healthy males that give their sperm, donate their sperm actually for money.
For money?
Yeah, but they don't get paid too much.
Oh, I see. You don't want them to, you know, losing their potency or fertility.
So we used to use medical students, and so you can go to a sperm bank and look up the characteristics of the male, whether the male's interested in music or philosophy or has a high IQ, mostly medical students, so the IQ should be a little bit better. And then you can buy the sperm, and then we just, same thing, intrauterine insemination, just put the sperm into the uterus of the female, and quite high pregnancy rates.
Could you put slide number 10 up, please? There you see, that's how it's done. Right there are the sperm samples, or the contributors, or the what's in the marketplace as of that's a Tuesday marketplace, probably. Yes. But I'm really curious about one of the things that we do in biotechnology is work a lot with DNA. Do you think that there'll be matching in the future, DNAs and sperm donors, to get a better match?
You know, it's interesting that I've been tracking my patients, and when we had a sperm bank here for our medical students, and I felt badly because all the tall students were chosen. Even though the husband or the partner was short, the wife chose the really tall donor. So that's almost like subliminal DNA matching.
I know. Wow. Talk about eugenics. I mean,
I think in the future we can do that.
I mean, I would think that if you can, break down the chromosome structures, you can certainly, match up attributes of amino acids with each other and kind of find almost a perfect match if you have a big enough universe contributing to the banks.
Oh yeah, that's for the future, and that definitely will be done, no question.
Okay. Let's go on to that next that big areas that I know that in your field it's divided between IVF and IUI, in vitro fertilization and intrauterine fertilization. What is in vitro fertilization?
That's one step further. So IUI was the first major breakthrough, intrauterine insemination, where you take the sperm, wash it, concentrate it, and put it into the female partner. Then people started thinking, well, maybe we can take the embryo, the eggs out of the ovary, fertilize it with the husband's sperm. So you now have 100% fertilization rate, so that area is taken care of. And then just put the embryo back into the uterus. Then you only have to worry about implantation, making sure that embryo attaches to the wall. And so that was the major breakthrough.
Without being facetious, I mean, I know you don't use crazy glue to attach them to the wall, but how do they attach so quickly? Yeah, and how do they stay hanging on there? I mean, this is like, fight for life, for the survival.
That's the major question. If we could figure that out, we'd have 100% pregnancy rate.
Really? Yes. Oh, you mean most of the non-pregnancies occur because of the fact that they detach from the wall of the uterus?
And yes, or they never attach, and so that's the major research.
So there is actually no answer yet to why fertilized eggs don't attach or remain attached.
Well, one answer is that the older eggs don't attach, or the older embryos. The younger embryos will attach. Again, with our donor research, we have a 20-year-old egg, fertilize it with an 80-year-old guy, and 100% pregnancy rate, almost. So as long as if you have a young egg, it doesn't matter about the sperm, so it's the age of the egg. So the older the egg gets, the more difficult, I think, the attachment process becomes.
And what is IVF with ICSI?
That's a third breakthrough that we have.
Okay.
And that's where men with low sperm counts, the sperm just cannot get into the egg. And so we actually push the sperm right into the egg. We take one sperm
Yeah.
and just push it, and we thought, wow, it's going to hurt the egg. It doesn't hurt the egg.
Really?
Actually,
Is this prior to, is it because it's post-subdivision or is it pre-subdivision?
Pre-subdivision.
Okay.
So you have the egg and the sperm, and you just take it and just, you actually have a small pipette, a tiny micro pipette, which just, you stab the egg and then shoot the sperm into the egg, and very safe. And babies come out fine, and so that was, I would say, the third major breakthrough was to do what we call intracytoplasmic sperm injection. We actually inject the sperm right into the egg. And so for a male, we used to say when I was, at medical school, you had to have at least 70 million. And now we're down to 20 million because of intrauterine insemination. And we can conceive with 5 million. And now with only one sperm, if we can find that sperm, we can just inject it into the egg and fertilize that egg.
So does the chance of fertilization and pregnancy increase with the number of eggs that are actually inseminated?
Oh, yes.
So you're playing an odds game. If you enter 3 of the horses from your stable into the race, you're going to have 1 out of 3 chances. If you have only 1 egg, obviously your chances are cut down.
That's correct.
Okay. See, folks, it's all about the sports betting in America. It's all about betting on the right horse. What can I say? Could you show us slide number 13, please? Okay, so here we see an IVF with donor eggs. Now, this is something that you don't hear too much in public, because many of the times that we hear of multiple birth, it's actually younger women that have actually undergone a hormonal injecting and have more suitable eggs. Is that the way it is, or more eggs dropping into the...
Yes, that's correct. And what happens is with a younger egg, you need to put only two embryos in, and you'll have 30% twin rate, so it's quite
really
high. And almost 100% pregnancy rate, again because of a young egg. So you could take a young egg, and that's a donor, and they get paid a lot more than the males do. And when the males donate, they don't get paid that much. I don't know what it is now. It used to be $25. So.
I guess you can't make a living off that.
Maybe it's $100
I guess this is not a viable job
for males. No,
for males, no.
Maybe it's $100 now. I think probably not much more. But the donor women who donate their eggs get paid about $4,000.
Really? Wow.
And I know for some of the women's colleges back east, it's like $20,000 they get paid. So some couples want an Ivy League woman's eggs.
I see. That discrimination. Even though I'm a Columbia graduate, and I known that this was such a high valued product, Ivy League. Well, I didn't recognize it at the time. So you were talking about donor eggs, and what about some of the psychological issues on the one side of the person donating the eggs, assuming they're not just doing it for money? And on the other side, you look at me like that might not be a correct assumption.
Oh, no, that's correct. We send everybody through psychologists.
Okay.
We want to make sure that everyone knows what they're doing. So they all see a psychologist.
Okay. So, and on the other end, the person who's going to have an egg that is perhaps purchased or donated by someone, what are some of the psychological ramifications here?
For the husband or the male partner, it's okay because it's going to be his child, his DNA.
I see.
For the woman, it's not her DNA. But then she carries the embryo
to term.
To term, and so, it's interesting if it's a girl, it's going to look like the mom. I don't know why. It's just interesting that if it's a guy, it's going to a male baby will look like the father because it's his DNA. But if it's a girl, it's amazing. They look just like the mom.
The birth mother.
The birth mom, but of course she chooses a donor that looks like her too. So again, they have pictures, and they have does a donor whose egg she'll be receiving play music. I mean, they have a lot of how tall is she? Again, they always choose tall donors, which is interesting.
Wow, I guess that's why I was never chosen. I guess it's the heights thing. No, but all jokes taken aside, you've been watching Boritzer's Bio Briefs. We're going to take our halftime break over here. Our guest today is Dr. Thomas Kosasa, Chief Endocrinologist, Reproductive Endocrinologist at the JAB School of Medicine. And I should mention also, he has his own practice right here in Honolulu. I'm told jam-filled, and he needs just a double life. He needs a double. Maybe this is the subject of a movie. I was a double for a reproductive endocrinologist. But in any case, we're going to get right back after our commercial break and continue with our discussion on reproductive services, technologies in the future.
Aloha, I'm Nicole Horry for Think Tech.
Yeah, that to me.
For
like,
nearly half a century, the Hawaii Foreign Trade Zone Number 9 has brought the benefits of the Foreign Trade Zone program to Hawaii businesses and entrepreneurs. DBET, the Department of Business, Economic Development, and Tourism, operates Hawaii's Foreign Trade Zone program to encourage international business and economic development. The Foreign Trade Zone's mission is to increase the amount of international trading activity in Hawaii, thereby providing employment opportunities for the residents of our island state. For more information, see ftz9.org. I'm Nicole Horry. Mahalo.
It's easy to go to California.
We're back here watching Boritzer's Bio Briefs. My guest, as I said, Dr. Thomas Kosasa, Chief Endocrinologist, Reproductive Endocrinologist. I didn't know why those two words should naturally go together. But we're talking about the use of various technologies to improve the reproductive rates in women and couples and people who would like to have children, and perhaps for one reason or another, whether biological, endocrinological, age, chronology, and so on, are having difficulties. And there are answers. We're doing this particular show because we know that there are many people who have questions. They want some answers. They don't always feel comfortable asking their physician or asking their best friends. This is not a topic that's highly suitable for cocktail parties or perhaps sitting around a coffee clutch with your favorite friends, because it's always grist for the, how you say this, grist for the mill, so to speak. And I know that America is very advanced in liberal countries, but in some subjects sometimes the sensitivity is lacking, especially when it's not your problem, when it's someone else's problem. One of the things that's often is asked, and I think when you were talking, we were asking about having multiple eggs, you know, if you can have two of them coming down or three being in place and fertilized. And then you mentioned the number of multiple births. And one of the questions is, when you're doing IVF, what are the chances of having multiples?
That's an age factor. If we have a woman's own eggs at the age of 40, it's almost never, even though we put 4, the American Society for Reproductive Medicine has guidelines for us, and at 40 we can put 4 embryos back in to try to get 1 baby.
Oh, because you simply divide the percentage of 25% chance by 4. You multiply it, actually.
Yes, but and so for some reason when you put 4 in, the chance really increases from maybe, you put one embryo in at the age of 40, you maybe have a 10% chance or maybe 5% chance. If you have 2 embryos, a little higher. At 40 though, even the best institutes are about 20% for pregnancy rate. And again, it's age factor. So we can put 4 in at 40, but at 20, if we have a donor embryo, it's 2. And actually, there's a growing body of institutes now that are only putting 1 in, but that decreases the pregnancy rate. And so if we put 1 in, you have maybe a 60% chance of conceiving with a donor egg at 20. If you put 2 in, it's going to be up to 80-90%. So
really,
and if these couples, by the time they go to donor egg, are in their 40s, and so they want to have two children at one time. So they don't. That's it. They have their.
I see. They say, if I'm going to be awake at night, might as well be for 2 kids crying instead of 1.
And they have their whole family one time. They don't have to go back again. So they're looking for twins. They want twins. But the difficulty is that, in Hawaii we have 2 private schools, and every year now we're getting 20 sets of twins applying to maybe only 40 spots for kindergarten. because of the IVF. And so the presidents of both schools have called me saying, you know, you need to slow down, you know, too many twins applying. That takes away spots from other people.
So we hear these sensational stories in the press. We see we see the woman who had 8 or 10 children. What is that all about?
The physician put in too many embryos, and that was just, you know, not I think, well, not correct actually, and not medically astute also.
I see. It would have been okay if she had been perhaps 45 years old, just to work the percentages. But when you are 28 or 35, your chances of conceiving are much better still.
Oh yes, and so the guidelines are really maximum of 4 embryos, and so those are the guidelines. So, and we don't hear that too much because the society is now becoming much more alert in terms of physicians who, you know, are doing this, and so we only put in 4 maximum.
Just as a social commentary, how do you feel about people who almost become, how you say, a circus act? Where, you know, to going through this process and suddenly have 5 or 8 or 10 children. I mean, is there some kind of ethical question here?
I think so, and the doctor too. I mean, that's, you know, I mean, the person that did that for Octomom actually lost his license in California.
Really?
For doing that, because that was, you know, not the right thing to do. Yes.
And what is IVF with the blastocyst transfer?
The blastocysts are with the donor eggs. When we first started IVF, we could only get the embryos to grow to day 3, which is 8 cells. And again, from day fertilization to day 3, the embryo only needs glucose, so just sugar water. But to get to the blastocyst stage, that's day 6, there's trace vitamins, amino acids. It's a different. The lab has to be really, really very good. And the blastocyst.
Oh, so you mean that's still in the stage when it's in the laboratory before it gets inputted?
Yes, and so the blastocyst has about 60 cells. So you go from day 3, 8 cells to 60 cells by day 5 or 6. And again, with the donors, they get to blastocyst very easy because they're young eggs. Someone who's 40 may not be able to get there. The eggs just cannot survive that step to get to day 5. And if we put a day 3 embryo in 8 cells, we, again, 40, 50%, 60% maximum. Blastocysts, you know, 80, 90%. So again, the donors all get to blastocysts. So that's where the donors become, you know, highly valued.
Could you show us slide number 15, please? Yeah, these are the blastocysts.
So you can see there's a 4-cell stage. It starts with 2 and then 4. 2 is at fertilization day 1, 4-cell day 2, 8-cell day 3, and then way on the lower right-hand corner you have 60 cells. That's the blastocyst. And that's
almost a guaranteed birth.
That's almost a guarantee, yes.
But again, the question that we raised before, that even at that advanced stage, the attachment to the uterine wall is still an issue.
Yeah, so even that 40-year-old that has a beautiful blastocyst, you know, won't have an 80, 90%. It'll be like 20, 30%.
Really?
Again, the attachment factor.
So I would think that a really important part of your job in dealing with patients or clients in reproductive technologies and reproductive medicine is to almost the education process of educating the patient in what is going on, what are the chances. You almost have to educate them prior to them going for their first bet in Las Vegas, hoping to make $1 million or win the lottery or something, and you have to almost temper down expectations. Almost the reality has to at some point be made apparent.
That's true, but it's amazing though, you know, even at 40, if you keep going, it's amazing how many people become pregnant. I mean, it's just so I never give up. That's, you know.
That's a good attitude.
Yeah,
when I was in the Israeli military, my sergeant always said, "Don't give up now, don't go." I said, "But I'm tired and hungry and thirsty." But that's another story. We're going to take a break and come back for our final segment right here. You've been watching Boritzer's Bio Brief. We're going to return with our guest today, Dr. Thomas Kosasa of the JAB School of Medicine at the University of Hawaii.
I'm Hong Jiang, host for Asia in Review on Tuesdays.
And I'm David Day,
host for Asian Review on Thursdays. Both of us broadcast our respective shows at 4 p.m.
And my topics tend to deal with questions related to environment, culture, history, and sometimes human rights.
And my shows tend to be on international business, foreign policy, geopolitics, and national security. And you can watch our shows live on the ThinkTech website at thinktechhawaii.com.
And you can also watch us on YouTube or Olalo.
So come join us on Thursdays at 4 p.m. I'm David Day.
And on Tuesdays at 4 p.m., I'm Hong Jiang.
Aloha.
Aloha.
It's Bio Briefings right here on ThinkTech Hawaii Television. Our guest today is Thomas Kosasa, and we're going to, as I said, conclude the show with some 4 or 5 topics that we still want to cover, and one of them is using donor embryos.
Yes, highest pregnancy rate, almost 100% with donor embryos. And again, we talked about the fact that you can go through a catalog and choose. And so again, if it's a male baby that comes out, it's okay because it's the husband or the male partner's DNA. For the woman, if a baby comes out looking like a girl, or is a girl, it'll look like the mom. And so that's, to me, been really amazing.
So let me get this straight. When you're talking about a donor embryo, the potential parents, or the physician with their potential parents, or how does it exactly work? Tell us about the process of.
I'm talking about donor eggs, but
yeah.
So donor egg means that the husband is half, the DNA. A donor embryo is an embryo that someone donates, and so they carry actually somebody else's DNA all the way through. So, and we're doing more and more of that, but you worry about somewhere in Hawaii where you may have a sister or that you don't know about because that was a donor embryo, and so that's something that we don't do too much of it. Oh, you mean
then when you get to be an adult, you might be dating your sister?
Yes. So
there has to be some kind of, I would think, a registry somewhere.
The donor embryo does have a registry, and we don't do too much of that just because of that issue.
Oh, so you do mostly donor eggs?
Yes, donor eggs, but very little donor embryos, yes. And if they're donor embryos, we probably fly them in from the mainland. We get a frozen embryo from the mainland, so the chance of the person growing up and dating their sister is much less.
Tell me a little about the technology. So I can understand how spermal fluid can be cryogenically frozen and kept. How does it work with an egg?
With the embryo is very easy to freeze. The embryo, once it's fertilized, you can keep that embryo forever. I have the second, I think, oldest. We had a patient who waited 9 years and decided to have a baby. So after 9 years, we unfroze the embryo, and she had a baby. I think in the mainland there's maybe 10 years or 12 years difference, but that's a long time between your first and second child.
And how about the donor egg? How does that survive?
Donor egg now was much more difficult to freeze, but now we have the technology, so we can freeze eggs, and that's a major, maybe the 4th major step, because we have a lot of medical students who are women and no boyfriend yet, no husband to be, and they can see their fertility. They know because of our research that after 24, every year, it becomes more difficult. So we can freeze their eggs, and when they meet somebody, we can take that person's sperm and fertilize their egg.
And so when let's say a young lady who's not married or not planning to be married or not planning to have children, she knows that she's prior to menstruation, she has the egg. The eggs are going to be coming through. How does she goes to an egg bank?
Oh no! What we do is we take her, we give her the medication to develop her eggs, maybe 8 or 9 or 10 eggs,
okay.
And just that's a IVF procedure, but instead of fertilizing at the very end, we just freeze her eggs.
Oh, so the eggs get frozen as well as just in the same way that spermal fluid is.
Yes.
Okay.
Yes. So much more difficult to freeze an egg. but now the technology is there. So.
And does it go through the same, let's say, cleansing process that spermal fluid gets with the centrifuge that you described?
No, we just take the eggs out through the
one
IVF,
by one.
IVF process, like we do with IVF,
Okay.
and freeze them one by one. And so she can have her eggs frozen, and then when she meets somebody in the future, have a baby.
And what is the longevity of sperm and eggs?
Essentially forever. We can.
Really?
Yes. So we can keep them a long time.
Okay. And two more issues, and then I think we'll be able to conclude our program today. And one of them is surrogate pregnancy.
Yeah, that's a field that we do a lot of now. And so for someone who maybe has a medical problem, maybe she has a heart problem, and to deliver a baby, her own baby, would be medically not a good idea, we can take her eggs out, fertilize it with her husband's sperm or male partner's sperm, and then put that embryo into someone else who now we pay. Or sometimes it's a friend, or it could be the mother that, you can be a mother and still carry your daughter's embryo.
But will attach to the uterine wall?
Oh yeah, it will, because it's the age of the egg.
Oh,
so
I see.
The uterus doesn't matter. The age of the uterus doesn't matter. And now we find out more and more friends are doing that for their good friends. You can use a sister, or so the age doesn't matter. So you could use your mom to their mom.
So what you're saying actually is that there's no excuse for not having children.
That's true.
The technology is here for almost any combination or single problem that you may have. You can overcome it in some way. Sometimes a little longer, sometimes for a longer period of time, sometimes at an older age, a younger age. All the problems have maybe not perfect solutions, but certainly solutions that are workable and have been tried and proven to a great degree.
Well, that's correct. That's why we say everybody can have a baby. I think that's a great thing with our field, that we can tell someone that you can have a baby, and it may be, as you say, a more circuitous route, but everybody can have a baby.
Now, one of the things that's right now very popular in America, but it's been popular in Europe for a much longer time, is the influence of our behavior on our ability to either engage in athletics, live longer, have longevity issues, no longevity issues. One of the things also that many times are mentioned with regard to pregnancies and fertility and so on is how you behave, what you eat. Do you exercise? How much sleep do you get? These are all factors that contribute to the general health. How important are they with regards to fertility and pregnancy?
Well, I think those are good factors, and the one thing we found out is that exercise is not good to try to conceive.
Okay, so exercise is out. Do you hear those folks? All of you who are feeling guilty after New Year's, you made all these resolutions. If you want to get pregnant, here's one place where you can cut down.
Yes, and then we did studies showing, again, my colleagues in Boston showed that just walking 4 hours per week, which is nothing, reduces your chance of conceiving 50%.
Really?
So it's best not to do anything.
Ah, that's why my wife says that I'd rather lie down. Why don't you prepare dinner?
Yes, that's correct.
I see. So this is actually part of the treatment that you suggest.
Yes,
lie down, relax.
Right. And no shopping. Someone else.
Well, shopping is good.
Yeah,
I think that could be part of the positive side of this particular preventive medicine.
No shopping.
Okay, but how about smoking?
Smoking a little bit, yes, smoking does, and alcohol a little bit too. No caffeine though.
Caffeine is a no-no.
Yeah, caffeine's a no-no.
Okay, so ladies, gents, well, I guess this doesn't affect the gents that much, the alcohol and the tobacco.
No, that's...
Even their genes are not going to suffer.
Yes, and that's, yes.
You're not a big proponent of not smoking and healthy eating and exercise. So gents, you continue exercising, therefore you should also stop smoking, stop drinking, and you're on your way to being a daddy really soon. I want to thank very much Dr. Thomas Kosasa.
So thank you.
Thank you for being with us today. It's been a really informative, enlightening, and for our watchers, listeners, viewers, and myself as well. and you've been participating with us right here at Boritzer's Bio Briefing. You can catch us on new streaming, thinktechhawaii.com, as well as YouTube, as well as on my Twitter site. Our Twitter site is BioInfoMedical, and catch me whenever you can. Until next time, this is Dr. Rafi.